Thank you very much, Elda. I'm honoured to be here, and thanks St George's. I've recently joined, as I say, in the last year and set up a cardiovascular pathology unit with the help of a charity cry, cardiac risk in the young, which I'm sure a lot of you in the audience are familiar with. And now, in our country, we've over 500,000 deaths. And the importance of it is the fact that all sudden, unexpected deaths, which we're interested in the main topic today, are reported to our coroner, our legal representative investigating all deaths. So 25 to 40% of all deaths in England have a post-mortem. In other words, we do an awful lot of post-mortems in England, 164,000. That is much higher than in any other country in Europe, particularly in the sudden death context, when there's no suspicious circumstances. The coroner is legally qualified, not medically, and 132 of them throughout England. And he is helped by coroner's officers. Sorry, I'm going the other way. These are the coroner's officers on either side, and these are vitally important to us pathologists because these are the people that provide us with the background information when there is a sudden death. So vital information is provided by them through the coroner. So a close relationship between the coroner and the pathologist is essential. Because as you can see there is lots of causes, and you'll be hearing about them all today, of sudden cardiac death, particularly in younger people. And my role as a pathologist and pathologist throughout England is to actually carry out the autopsy when it's a non-traumatic sudden death. Obviously eliminate non-cardiac causes, neurological, respiratory toxicology, negative toxicology. And then you look and zoom in the majority of cases, 90% are cardiac causes. And what we as pathologists have to separate out is the cardiac abnormality. Is there an abnormality we can identify both macroscopically and microscopically, or is the heart absolutely normal, a morphologically normal heart, where we come into the spectrum of sudden arrhythmic death or sudden adult death? Often the term unascertained is used by coroners, and it's not a term I like really. And now it's becoming more acceptable from coroners to put as a cause of death, sudden arrhythmic death. Now, where I got interested first of all is with the British Heart Foundation in the 90s with Tim Boker, and we looked at a prospective surveillance over 4 months between these ages. We did not look at younger patients with no previous history of any illness, last seen alive within 12 hours, and had a coroner's post-mortem. And we got a final cohort of 692 cases where we reported on them. And not surprisingly, we found the majority of sudden deaths are ischemic. 82%, very similar to what is in other countries. But 6% are linked to, cardiomyopathies. 7% we found said sudden arrhythmic death was the heart was morphologically normal. And this is one of the first studies establishing the entity of sudden arrhythmic death. Now it's interesting, acute ischemic heart disease, you may think it's pretty straightforward. An infarct in the ventricle, thrombosis with rupture of a plaque in a coronary artery. Easy to establish that that is your cause of death. But what if you've just one vessel that is significantly obstructed, or another vessel that's not so obstructed with no scarring in the ventricle or no damage? Are you quite confident that that vessel is the cause of the sudden death at that particular moment in time? And this issue I will come back to. In addition, there's an issue with pathologists of overestimating narrowing of a coronary artery. Here on your left you will see a narrowed coronary artery, slit-like narrowing. You may think that's significant narrowing. Yet I can insert a 2 millimeter probe into that lumen and open up that vessel, as it was during life, because there's artifactual collapse of a vessel at autopsy when blood seeps out of the vessel. So we pathologists can overestimate the significance of coronary artery disease. On the other hand, we may miss it, although in this case obviously not. We can get coronary artery disease in very young people. Here's a girl aged 11 who collapsed in a school run. This is her ascending aorta and her aortic leaflets, thickened by lipid-rich material. Lipid-rich plaques the aorta of what looks like an 80-year-old. And here are our coronary arteries, completely blocked. You can almost not distinguish them from the surrounding fat. And when the mother phoned me up, she told me, we have familial hypercholesterolemia. I have it, my father, my grandfather, and yet my 11-year-old daughter was not screened. She had been previously totally asymptomatic. You may also get precocious atheroma in people under the age of 35. And the type of atheroma you get is platelet-rich on erosion of the endothelial erosion, where you've got fibrous-rich plaques, not the lipid-rich plaques which rupture, and you get surface erosion and thrombotic occlusion. Single vessel disease predominates in these, and often related to alcohol, prior alcohol use, which I will come back to. In the United Kingdom, under National Service Framework, there was Chapter 8, which came out in about 2005, on arrhythmias and sudden cardiac death. And in that chapter, it was indicated about carrying out a full autopsy and investigation of a sudden death, which happens in a family, with the follow-on of screening of the family. In addition, there's been guidelines which we are now updating with the Royal College of Pathologists in the investigation of sudden death with underlying cardiac pathology. So we have got chapters, we have got guidelines, and we have looked at our cases. So from the work I did with the British Heart Foundation in the 90s, then into the 21st centuries, what we did is gather together all our cases that were centralising. When I was at the Royal Brompton Hospital, looking at our sudden death cases we published. And the percentage, males predominate, which you're all very familiar with. And the other point to remember, the majority of the cases referred to me were normal heart. In other words, channelopathies predominate in my referral practice. The other main entity is the cardiomyopathies. In other words, you've got 3/4 of cases which are potentially inherited diseases among our sudden adult or arrhythmic deaths. That's important. But in addition to cardiomyopathies and a normal heart, I tell pathologists, always look at your coronary arteries, not just for atheroma, but you look for anomalous coronary arteries. They make up 3% of our cases. So look carefully for all these entities, which are anomalous origin, coronary artery dissection, vasculitis, stenosis, atresia, right? Idiopathic calcification. Rare entities, but should be actually looked for by the pathologist when they're investigating these sudden deaths, particularly in younger people. Here's an example of anomalous coronary artery. You have the two ostia in one sinus, the left arising from the right sinus, going between the great vessels, causing sudden death. And here's example, another case, high takeoff, which is well above into the ascending aorta. Here is complete atresia of the coronary artery associated with infarction and fibrosis in the ventricle as a cause of sudden death. And I also tell pathologists that not all narrowing or blockage of a vessel, particularly in young people, here's a boy of 13, is not atheroma. You have to take histology. You have to look under the microscope of all cases, because this is an example of fibromuscular dysplasia, myofibroblastic proliferation into the intima of the vessel, no atheroma, no lipid, causing obstruction of the vessel. And this happened to be a genetic disease in children. His brother had died 10 years before in similar circumstances with similar pathology, which had been mislabeled as atheroma. And also, in addition, not all thrombi that you see in coronary arteries are due to atheroma or ruptured plaque. Here's a naval officer, died at the age of 35, thrombus. But what you see, the thrombus is in the media. And here is the collapsed lumen of the vessel. It's an example of idiopathic dissection of the coronary artery, not familial, linked, seen in pregnancy, particularly in postpartum females. In males, linked to cocaine use, so toxicology is always very important. So here's the difference. Here is bridging, here's a dissection, here's an actual mass, a lipoma obstructing a coronary artery. So always look carefully at the origin of the coronary arteries in the aorta, not just at their distribution on the epicardial surface of the heart. Here is idiopathic calcification of infancy. This is particularly in sudden infant death that you look carefully for calcification and obstruction of the coronary arteries in childhood, particularly in children under the age of 5. And you may get a myocardial infarct without occlusive atheroma, which is presumably due to spasm. And we've published on this, on idiopathic, what we call myocardial infarction, particularly younger in 30s up to 40s. Idiopathic infarction, generally acute infarcts, and in our study it's been linked to alcohol use and also cocaine use. So cocaine plus alcohol, a lethal combination in particularly younger people. So we established, as I said, at St. George's in the past year, we transferred the CRI Department of Cardiovascular Pathology. And with my colleagues, particularly this is Jan Lucas Robertus from Rotterdam, paediatric pathologist and general pathologist, refer cases to me from throughout the United Kingdom. And more recently, the chief coroner, Peter Thornton, has indicated that all cases should be reported to our central database that we've established. In other words, we get a handle on the national incidence of sudden cardiac death. And this is very important. With his appointment as chief coroner, he tells the other coroners now what to do. So they have to be guided by him. So that's a very important step we've established nationally. So in addition to the report and the heart being sent, a small piece of spleen for genetic analysis, the concept of the molecular autopsy has now been established in practice throughout England. So here is the heart. We always tell pathologists, send the whole heart if you can. Looking at the coronary arteries carefully, we section it, we look, we do a microscopic analysis, we report. This is important. We guarantee the coroner and the family that we will issue a report within 14 days. And we also put it on our central cardiac database. This is very important. These are the criteria: cardiac arrest, history of death following impact to chest, drownings where circumstances, road traffic accidents are not quite right, found dead at the wheel of a car, toxicology is negative, or non-toxic levels of drugs are found. So these are all the spectrum guidelines I give out to pathologists and coroners' officers throughout England. We also have a questionnaire for the family. Medication, previous history, previous ECGs, previous family history, previous sudden adult death, sudden infant death. These are all important questionnaires we send out as well to the family. And these are the autopsy findings that we say, send us the case. Normal heart, dilated looking heart with normal coronaries, fatty looking heart, scarred, anomalous coronary arteries, because they're so rare, we would like to look at them, although they're generally not familial. Ventricular hypertrophy, coronary arteries with obstruction and dilatation, not due to atheroma, coronary atheroma in under 35s because of familial hypercholesterolemia, and aortic dissections in people under the age of 40 with no history of hypertension. And we also include congenital heart disease because these are complex cases that really need specialist autopsy analysis. We have a lot of paperwork because it's Human Tissue Act is very precise about our handling of human material. So we have to have consent for retention of any material we have. So we have detailed documentation. I won't bore you with it, but importantly, send the heart in a specific container and also send the spleen in RNAs later. In other words, the splenic material can be sent at body temperature. It doesn't need to be frozen. We freeze it once it arrives in our department. So it means in mortuaries they don't have to be freezing or looking for liquid nitrogen. We examine the heart, we do our measurements at mid-ventricular level, we take our samples, I won't go into detail, 10 blocks of material, we tell the family it's the size of a 50p piece. That's telling the family you're only taking tiny pieces of tissue. We can return the heart for burial depending on the wishes of the family. And this is very important. We take the conduction tissue and we issue a report within the 2 weeks. And here are results of now what we have, nearly 4,000 cases. Again, SADS predominates, 55. Maybe we're actually obviously referral bias because pathologists want to make sure it's a normal heart. And again, we've got the cardiomyopathies in 3/4. So 3/4 cardiomyopathy and sudden death itself, with the rest being aortic, myocarditis, etc. Now, looking at sudden death, where interpretation of findings, this is very important because significant findings, how significant is a finding? Like atheroma, right? What if you've got an inflammatory infiltrate? How much inflammation do you need for a diagnosis of myocarditis? They may seem pretty obvious, but they're not really, right? And you can see the sudden deaths, both in athletes, we've looked at in the UK, as well as in our national database. And you can see here, that we've got SADS, 23% among athletes, less in athletes, hypertrophy more dominates, as you can see in athletes, 31% hypertrophy. Whereas in the general, it's SADS predominates. And when we get these and we make a diagnosis, what I then do is I go to my colleagues, Elijah and Sanjay, right? And they're the people who will screen the families. Sorry, I'll go back again. And here is work that Elijah has done, showing the follow-up and the diagnosis made in particularly the SADS cases. And these feed back to me with follow-up, which is vitally important for me as a pathologist. And again, with Sanjay's interest in athletes and sports medicine, looking again at the hypertrophy cases compared to the SADS cases, with a special interest in what are the causes of hypertrophy. And HOCM does not predominate. In our series, it's idiopathic left ventricular hypertrophy predominates. So 31%. So again, we're looking into these cases as to the cause of the hypertrophy. Because what's our definition of HOCM? For HOCM, you need myocyte disarray. That's important. Whereas idiopathic hypertrophy, there is no myocardial disarray in the left ventricle. Again, in ARVC, one has to have fat and fibrosis, not just fat alone, because you get fatty infiltration in the right ventricle in obese patients, in normal people. Fat alone is not indicative of arrhythmogenic right ventricular cardiomyopathy. And pathologists overestimate the importance of fat in the right ventricle alone. Again, with coronary atherosclerosis, it's easy to say you've got a sudden death when there's infarction, but when you've got luminal narrowing, but it's less than 50% here, is that significant? And if it's 2 millimeter probe patent, has that a role to play in the death? Most unlikely not. And these are issues for the pathologists when they're looking at these cases. And here's 158 consecutive cases where we reviewed what the general pathologist did and what we did when we made the analysis after the heart was sent to us. And this is work done with Michael Papadakis. And what it shows was diagnosed by the general pathologist as ARVC, turns out to be normal heart. We put it into the normal category, overinterpretation of fatty infiltration of the right ventricle. In addition, what was labelled as hypertrophic cardiomyopathy, when we reviewed the cases, they had no myocyte disarray. So they joined either the idiopathic left ventricular hypertrophy or the normal hearts. And again, where you had inflammation, so-called myocarditis, we considered there was not enough inflammation for myocarditis. And again, those cases joined the normal category for recategorization. So you can see, again with valve, particularly mitral valve disease, reassigning it a normal finding in particularly older people. So in other words, we're redistributing when we've seen the cases, we're redistributing them to a normal category or other categories. And this is very important where you need a specialist referral or audit of autopsies. That's very important, I think. And this comes through with the work that Michael did, showing that in entities such as floppy mitral valve, minor coronary artery disease, when you had myocardial inflammatory infiltrates, they, on family follow-up, turned out to have channelopathies. And again, right ventricular fatty infiltration, ventricular dilatation, where pathologists label a ventricle as dilated and call it dilated cardiomyopathy. And again, hypertrophy of the left ventricle is an entity that is argued about among pathologists. And these on follow-up have found to be channelopathies. And here's an example I had recently. Inflammatory infiltrate. 2 of them in a left ventricle. Just 2 foci. So will I label that as myocarditis? Some pathologists would say yes. I think I've been warned here to come to an end. Again, floppy mitral valve, here hooding and thickening of the valve. Its role in causing sudden death, particularly when the ventricle is not fibrosed or dilated, is an actual controversial area. So normal heart, you can follow up, show channelopathies. The same with ischemic heart disease. So coroners, this is a final note to say. Coroners have to pay for histology, so they try and discourage taking histology at autopsy. The coroner has a limited budget. There's no audit of coronial autopsies in this country. Guess how much a pathologist gets for each post-mortem done? Some people in the audience will know. What do you, others, how much does a pathologist get? Pardon? £90, correct. Just here. This is what you'll get as an answer when you give them £97. Thank you very much.